Welcome to the third week, I think, of DDU program, and we'll talk about the right ventricle and pulmonary hemodynamic assessment today. I think it's a little bit hard to it's so much to pack in right into one session, so there's going to be things that I cover a bit, usually my biases, and then there'll be things that I sort of skip over. But just ask questions. It is going to be a little bit didactic, unfortunately, because there's things that you just need to know for the written and things like that. But I'll try to quiz you and ask questions as we go along. Don't worry if you get things wrong or you don't know anything. That's what we're here for. And I don't know all the answers, but hopefully I can look it up and we can get there together. All right, so it's what we always start an RV talk, don't we? With the RV being like the underdog, and that's because of all the the sort of old studies back in the the mid sort of 20th century and things like that, of sort of dogs being their RV free wall being cauterized and their cardiac output not really changing with a sort of open pericardium and all those famous studies that really led on to the LV being the powerhouse and the RV being neglected. But things sort of changed when the Fontan procedure and things came along, and everyone started to pay a bit more attention to the RV being important. And I think you'd have no one disagree with you now. And when we say that the RV matters, obviously there's a wealth of data showing its prognostic importance in pulmonary hypertension groups outside of the ICU and heart failure, in those sort of groups. But emerging data over the last decade, even longer, of how important it is for our critical care population as well, so people that are acutely unwell. And I'm sure you're familiar with publications like this in sepsis and ARDS, where the odds of mortality with RV dysfunction are significantly higher than those without RV dysfunction. So it's now acquired the name of sort of the people's ventricle, or the intensivist ventricle. We claim it more for ourselves. This is probably one of my best, like my favorite things about what I've read about the RV, and it was from Pinsky and Quick Care. And it said the RV is not considered important for cardiovascular performance until it is. And it's so true. You kind of, if you don't think about it, you miss the boat, it's gone, and you enter that spiral, and it's really hard to pull the RV back, which is why I'm so interested in it and why I like teaching about it. The problem with RV injury, RV dysfunction, is that the definitions are very messy. I used to think that it's so messy, we need like just a perfect silver bullet to know what we're all talking about. But I'm increasingly becoming a bit more skeptical of that, and I think it's more about RV patterns. And I'll come back on to talk about the different, how we can sort of think about RV phenotypes. But anyway, the definitions of RV dysfunction, they are pretty messy. If you look at the literature, there's fractional area change, TAPSE, subjective assessment, S prime, RV strain, areas and ratios. And you can see in this systematic review by Stephen Huang and colleagues here at Nepean, is that the number of studies that use different metrics of RV function. I mean, it's each one pretty much uses a different thing. The most commonly used metric in this systematic review was TAPSE. And there's not only this systematic review, there's more, with definitions in the teens of how RV dysfunction's been defined in those studies. So it is a big heterogeneous sort of hodgepodge of definitions. But I think we, in some ways, just have to live with that and enjoy the grey zone, the messiness a little bit. Maybe it keeps it fun and entertaining. And then Ben, who I think is just joined actually. So Ben has recently done a systematic review, meta-analysis, looking at the RV dysfunction, but really focusing on long-term mortality. It's not currently published in its full form yet, but it's really interesting findings, again consistent with looking at short-term mortality, that if you have RV dysfunction, your odds of dying later, is sort of long-term mortality is much higher. And again, in this systematic review, there was lots of definitions of RV dysfunction used, which makes it obviously difficult to hang your hat on one particular thing. which potentially plays into this, which is there's no known sort of perfect treatment strategy to improve patient outcomes with RV dysfunction. And really a lot of what we do, and there's this lovely scoping review sort of talking about that and how there's really not that many RCTs, and again we need more sort of good, robust, quality prospective data to try and help. But again, I think it's difficult to tease this stuff out in RCTs, isn't it? And I think a lot of what we do is based on physiological rationale. But I think we do have to remain optimistic that we will have, more evidence emerging, showing benefit from some of the things that we do on a sort of bigger scale. So I guess, most of the RV dysfunction that we are going to see in the ICU, it's related to pressure overload, isn't it? Usually ARDS, mechanical ventilation, PEs, sepsis with pulmonary vascular dysfunction, sepsis, ARDS, so sort of patients that are intubated with that. That's the bread and butter of what we see in terms of RV dysfunction. But don't forget, there's obviously RV volume overload as well. We shouldn't forget to look for right to left shunts if we see unexplained RV dilatation. We've picked that up quite a few times, big ASDs that have been missed. I think we've had about 3 in the last couple of years at Nepean alone. So it's definitely worth keeping in mind. And also about 20% of patients with ARDS, moderate to severe ARDS, will have a right to left shunt through a PFO as well. So not that it's going to give you significant overload, but it'll make your hypoxia worse. And then, of course, there's lots of things in critical care that give you contractile dysfunction of your RV, not just MIs, but just intrinsic dysfunction, which is complex, and I don't really fully understand it all, but all these sort of cytokine insults and all of that when you're septic, and all these other, insults from acid-based disturbances to the RV intrinsic contractility as well. And we'll talk about this, but don't forget the LV. I guess when we talk about phenotypes, you can have isolated RV dysfunction and LV combined sort of biventricular dysfunction, and that can be with HFrEF or HFpEF. And I think we're increasingly recognizing the importance of phenotyping these groups and how important RV dysfunction is in patients with HFpEF as well. So I guess watch this space for how that evolves in the critical care literature as well. We'll talk a bit more about that. So of course, in the outpatient setting, we have these, or we like to think we have these sort of warning signs of when the RV is getting worse. Maybe their PVR, pulmonary pressures, will start to increase, their stroke volume will start to drop, their metrics of RV systolic function will start to get worse. They'll uncouple, and I'll talk through some of this terminology. And then they have this sort of point where they have early decompensation, and then they fall off their perch with RV failure. Of course, in the ICU setting, it's really not as linear and predictable as that. We have all of these acute dynamic disturbances in contractility and RV afterload, and that interaction between the RV and the pulmonary circulation, it's really non-linear. And patients don't follow this graph at all, even though it's a nice framework to work through. So, RV dysfunction, RV failure really is a time critical diagnosis, and we need to have a high index of suspicion, as we know from this. We've all seen this a lot of times, haven't we, where, just depicting how pressure sensitive that RV is and how it does not cope with acute pressure changes at all. Well, it copes with volume better, but it doesn't like acute pressure changes. And we need to act quickly and think of it quickly, diagnose it quickly, and act quickly, because if we don't, then we enter this spiral. And I'm sure we've all looked after patients like this, where once that RV is gone and they've developed organ failures, it's really hard to pull them back from that. So then, this is another question, isn't it? When and how do we assess the RV? Again, I don't think there's any golden rule to this. I think, the key things for me is that we need to, in any critically unwell patient, we always need to be suspicious for it. It'd be lovely to have a, sort of a pre-test probability schema where we think, oh, in that patient we need to definitely look at their RV, and in that patient we don't. But nothing's ever perfectly sensitive or specific. So I think you've just got to have your spidey sense turned on and be suspicious and look for it, and not only look for it, but look for it well. and obviously I'm biased as an echo talk, but echo is that it's the easiest thing to do initially. Sometimes you can't get views, and we'll look at things you can do when you can't do that with transthoracic, and when we might decide to use a P8 catheter. And someone really smart who I learned a lot from told me that you need to manage the RV with soft hands, and by that he meant do one thing at a time, don't rush things, be gentle. It's a very sort of delicate structure, and always reevaluate whenever you've given an intervention. I think that's a key thing as well. We're not always going to get it right first time, but the key thing is to look again at what the impact is, both clinically and with imaging, or with invasive hemodynamics, and see whether what you're doing is working. So when to be suspicious, this is, I guess, when I'm suspicious. Obviously, the easy ones, PE, patients with known pulmonary hypertension, with lung disease, patients that have come to us that are unstable after having an MI, patients with ARDS, of course. I think anyone that's mechanically ventilated, anyone that's critically unwell, anyone that's sick enough to need ICU with organ failures, and we should be looking at their RV, but that's clearly going to be too much work for everyone, and so we do have to know sort of the groups that are at higher risk. Sepsis, left heart failure, of course, they usually come hand in hand, and obesity and sleep disordered breathing. These patients are high risk as well. So for me, that sort of spidey sense does heighten whenever I've got an outline that's showing pulse pressure variation. Especially if that's combined, if you've got if you've got invasive hemodynamics in that, you've got that classic sort of picture of low cardiac index, high CVP, patients needing pressors, they're oliguric. But often I find that there's sometimes that knee jerk if you've got that pulse pressure variation to give fluid. Just always be mindful that could be exaggerated because your RV's failing, or you've got another reason for ventricular interdependence like tamponade or something. Usually it's obvious, sometimes it's not. So, maybe before giving lots of fluid for pulse pressure variations, just check that your RV is not struggling. We're not going to see these lovely right-sided failure signs, are we, in the critically unwell? They're often non-existent. So we need to look for other things, and often those blood tests that come back with with your LFTs being off, acute kidney injury, lactatemia, acidosis and coagulopathy, this is when everything starts, your sort of ears pricking, you think, oh, could there be RV dysfunction here? And you can see this patient had marked pulse pressure variation because they've got rip-roaring pulmonary hypertension and ventricular interdependence. And of course, the last thing that this patient needs is fluid. So let's get on to the meat of it. So how do we assess RV size and function using echo? Does anyone have any questions so far? Just a bit of background. Just interrupt and ask me any questions anytime. So again, we'll be familiar with this, but I think it's important to cover. So this, the RV is triangular when we look at it from the side. It's concentric when we look at it in cross section. It wraps around the LV. It's obviously thin walled, about 5 to 7 millimeters, much thinner than the left. The mass is about a fifth that of the LV. It's described as having 3 parts, which is the pulmonary valves, tricuspid valves here. We have this smooth sort of inlet, which is the smooth part of the septum. We have this trabeculated septum, and then we have the infundibulum. And this is important for how it contracts, because the inlet and trabecular parts contract first and the infundibulum contracts last, and there's about a lag time of maybe 25 milliseconds or so in between those things contracting, which I'll talk about in terms of the fiber orientation. It's important that we think about this a lot with the LV. I think we think about the walls and the territories. We don't do it so much with the RV, and I think we ought to. So obviously, in your plaques view, you're going to see the septum, which is an important part of RV function. It's described by some as the lion of the RV, and it does account for a fair amount of the performance of the RV. And there's some studies that have either the RV at free wall is completely scarred and akinetic, or people have put a patch over the RV, and as long as the septum's still working, you can still maintain a reasonable cardiac output. So the septal kinetics and function is an important part of the RV function as well. And in the plaques, we'll also do our RV inflow view, and that'll give us the inferior wall and the anterior wall of the RV. Sorry, this little thing's doing my nut. I have to keep moving it all the time. And then, of course, in the short axis, we're going to see the septum again, and then we're going to see various inferior, lateral, and anterior walls of the RV. And then as we move up towards the aortic valve, again, we're going to see the anterior wall and the inferior wall of the RV. And coming to the forechamber, this is where we see the lateral wall of the RV. And then again, we get a nice view of the inferior wall as we come to the subcostal. So just try to, as you're going through your views, just like we do with the LV, just get a, just sort of know a little bit what you're looking at in terms of whether it's anterior, inferior, or the lateral wall, or the sort of, the outflow tract. Because all of these are important function, and sometimes you can have regional changes as well, particularly in early stages of pulmonary hypertension or infarcts and things like that. So this is important, I think. The RV fibers, it's obviously quite different to the LV. Like the shape is different, the fiber orientation is different. Your LV's got 3 layers, your RV's got 2 predominantly, and you've got these circumferential fibers that run parallel to your AV groove in this sort of direction, wrapping around the LV and the RV together. Okay, and they sort of bind the ventricles together, which becomes important for its pump action. And then you have these deeper longitudinal layers, and the movements of the RV, then you have this sort of longitudinal movement, don't you, from base to apex, where your tricuspid annulus moves up towards your apex, and that's predominantly from these deep longitudinal fibers. But then we have that inward squeeze as well, which is that bellows effect, and that comes from these superficial circumferential fibers. And again, as I was saying before, the LV is really important to RV function as well. It contributes somewhere between up to 40% of RV function, of RV stroke volume and pressure generation comes from LV contraction. And that's at the points where you get this RV traction from LV contraction, at the points where your fibers are shared between the points of contact between your LV and RV. So you can't think about them as isolated structures. They come as a package. See the whole heart, as we say, because that ventricular interdependence, the impact of one ventricle on another, both in terms of size, geometry, and functionality, is important. And so these shared superficial fibers, these points of contact, the septum and the pericardium, all of these are going to contribute to that ventricular interdependence, which we talk about a lot in the critical care setting. There's some nice papers talking about this, Haddad and Ho, just reference there if you want to read more about it. So the RV, I like to think of the RV as a pretty chilled out ventricle. It is in health. You can see the differences in the pressure volume loops, which I'll talk a little bit about. As I said, it has about the fifth of the work of the LV. It's very efficient. A lot of this is because it's ejecting into this low impedance, highly compliant pulmonary vasculature. It's got a slightly higher end diastolic volume. It's more compliant, and as you can see, the LV has these isovolumic periods, whereas the RV has poorly defined / non-existent isovolumic periods. And it fills before the LV, slightly before the LV, and it finishes filling slightly after the LV. And the pressure in the RV, it peaks super early and it declines very rapidly. This is the RV in health. Of course, as the RV becomes diseased, chronically pressure overloaded and pulmonary hypertension, and you'll see that this RV pressure volume loop, it becomes more like an LV pressure volume loop, which is obviously quite abnormal, and it goes through these adaptive remodeling phases and maladaptive remodeling, which is all quite complicated, but I'll talk through a little bit of its relevance in the ICU setting. The reason why it's so efficient as well is because it has this RV hangout period. So we can see that the pressure peaks very, very quickly, but also declines very rapidly as well. And what I mean by this hangout, I like to think about it means that you're still getting forward flow into your pulmonary trunk, even though your RV pressure is lower than your pulmonary artery pressure. Right, so you've got this inverse pressure gradient, but you've still got forward flow, which is quite interesting, isn't it? And I like to think about this as does anyone know this goal, what this is, what this goal is, who it was?
Is that Beckham?
Yeah, it's when he scores from the halfway line. I forget who it was against. Was it Wimbledon or something? Anyway, so the ball's leaving, he's hit the ball, it's left his foot, and then it's gone from the halfway line. It just glides beautifully straight into that goal. But before it reaches that, he's already turned around celebrating, right? So it's got this, or it's a little bit like a basketball player, I suppose, when they let go of the ball and they sort of hang in the air and the ball's still traveling, towards the net. It's this sort of hangout period. And it just means that, in health, you've got this really low oxygen consumption and super efficient ventricle. And does anyone have any questions about that? Because it does become important when you start to think about the RV in disease and how your RV pressure volume loops change and things like that. Cool. So RV size then, let's start with that. So normal RV size, I'll go over this quite quickly, is about a third the size of, there should be less than 2/3 the size of the LV. So you've got a third in the RV and 2/3 of the LV. Your ratio of areas should be less than 0.6. If it's more than this, so more than 2/3 of the LV, but the LV is still apex forming, then that's mildly dilated. This is all subjective, of course. This is what we use on a day-to-day basis, and I think it's really useful, provided you're on axis and you've got good imaging. If your RV and LV are equivalent sizes, but your LV is still apex forming, that's moderately dilated. And if the RV is bigger than your LV, but your RV is apex forming, then that's severely dilated. I'm sure you've all seen examples of that. Can someone tell me where we would do our measurements to back up what we're seeing subjectively? Which one would you choose? The 4-chamber, the focus view, or the modified view? What's in the this one? This one, no, this one you would be overestimating because of how you're slicing through UMI. So the guidelines recommend, and the cutoffs that they use does anyone know the cutoffs for the base and the mid?
I think it's like 4.1 at the 4.1 at the base.
Nice, very nice. Yeah, 4.1, more than 41 millimeters at the base, and more than 35 in the midsection. And the length, I always have 79, but maybe it's 83. Does anyone know? Ben, do you know the length? It's somewhere around 80 centimeters. I forget. I mean, and this is the problem, right, with these arbitrary cutoffs. And there's increasing data that, it's different among sexes, it's different among ethnic groups, depends on your body surface area, all of these things. And so these are, yes, we use 41, but me having an RV of 41 versus a 6'5" guy with an RV of 41, that's a very different story, I think. But anyway, the cutoffs that you'll need to know for the exam is, and I guess, for your clinical practice, 41 at the base and 35 in the mid, and that's using the focus view, so this view here. And how do we get to the focus view? You move a little bit more medially here. Okay, so this is your standard 4-chamber. It's zoomed in a little bit. Just play that again, and what we want to do is bring that RV into focus. So we're going to bring our transducer a little bit more medially, and then usually you need a bit of anti-clockwise rotation as well, and then you get your RV view, RV focus view, and you can see the RV looks a bit better, a bit bigger in the RV focus view to do your measurements on. What have I got down here? Oh, that's just showing how you do the measurements. So in terms of areas as well, we generally, I have this cut off in my head. Again, I have the same for men and women. It is slightly different, but I always need to look it up if I'm going to make a call on that, because I can never remember quite the exact differences between men and women. But as a ballpark, if you've got an end diastolic area of more than 12 centimeters per meter squared, then that's dilated. And these cutoffs are usually based on the 97.5 fifth percentile, right? So they're sort of right at that upper end of what's considered normal anyway. So if you're getting above 12 centimeters per meter squared, then you've definitely got a dilated right ventricle. And then you can look at the RVOT proximal diameter, more than 3 centimeters. You can see this patient here. It's way bigger, isn't it, than 3? You can even see 1, 2, 3, sort of approaching 4. What other things do you notice on this? Who have I got? It's quite annoying. I can't see you all. There you go. Hi. Rishi, what do you want to just comment on what you can see in this picture? Like some of the pertinent features about the RV?
RV, you can look at the thickness of the walls. You can see a tricuspid leaflet coming into the picture. You can see any effusion around it. And you can grossly see how it relates to the sizes compared to the aorta and the left atrium, if it's enlarged or not. And
what do you think of this one?
I think it is it's mildly enlarged.
Great.
Yeah.
Yeah, it's dilated, and I mean, you wouldn't normally do your measurements for RV wall thickness here, but you can get the impression, hey, that it looks thickened. And what do you think of this structure here? What's this?
Can't see your cursor.
Oh, can you not? Sorry. Can you see that now?
No.
Oh, hang on. Let me laser pointer. Oh, can you see this?
Oh, the moderator band. You mean?
Yeah, moderator band, big
It's
beefy
quite
moderator
thickened.
band.
Yeah.
So, and there's also small pericardial effusion, which you usually find in, not usually, but you can find in severe pulmonary hypertension. It's actually a poor prognostic marker.
Yeah.
So even just putting, I mean, of course, you're going to need to confirm all of this in other views, but just from this one view, and you get so much information from parasternal long A, you're already thinking, oh, I think this patient has signs of pulmonary hypertension, of chronic, of cor pulmonale. Given that the RV looks thickened, it's dilated, and there's a really prominent moderator band, and then you'd go through your whole thing of doing a full study, looking at the whole heart and seeing their clinical history, looking at old echoes. Are they known to have a history of pulmonary hypertension and things like that? But you're already starting to get a feel for what you're going to be focusing on just from your parasternal long axis view. Yeah, I just take that off. And of course, the other thing that we can look at for RV wall thickness, and this is what's recommended of how we measure it, is zooming in a subcostal view using 2D calipers here to here. And more than 5 millimeters is RV hypertrophy, which is suggestive of chronic pressure overload. I don't know. I find this very, very hard to do, especially, I don't know, maybe harder in the critically ill, but even in the outpatient setting, when we're reporting these echoes, it's really quite difficult to see where the liver ends, where the pericardium is, where making sure you're not catching the chordae, the pillary muscles. I often find that I have to repeat it a few times, and sometimes actually just abandon using it. So it can be tricky to measure this, I think. So you need to look at other markers of chronicity as well, and I'll show you a few of them. Not just hang your hat purely on the RV wall thickness. I think more in the future as technology gets better, and it's also already getting better from when Sam did this study. Maybe he did it about 8 years ago or something like that. In the critically ill, it was difficult for them to get good 3D volumes essentially using transthoracic echo in the critically unwell, and it didn't correlate. They tried to correlate RV stroke volume through 3D measurement with stroke volume through Doppler, and the correlation was quite poor. and it, you know, cautions against the use of 3D in that particular study. But you know, as I say, technology is getting better, and all of this. So, you know, maybe I'll have more of a role again in the future. It's certainly validated against MRI values, which are the gold standard. And if you can get good images, good 2D and then good 3D images, it does give you accurate values. But for all of the usual reasons, it's difficult to image. It's behind the sternum, it's the most anterior, they're ventilated. All of these things make it tricky in our population. So we talked about RV size, RV function, which is obviously dependent on the interplay, like LV function of preload, contractility, and afterload, but also on heart rate, rhythm, synchrony, RV synchrony, and ventricular interdependence as well. And pretty much all of the echo parameters that I'm going to show you are load dependent. You need to bear that in mind when we're interpreting them, and some are more load dependent than others. So TAPSE is, I'm sure you're familiar to all of you. It's probably the one that's done most often. It's done in POCUS studies. It's very useful. It definitely has its place, but it's also got its limitations as well. So we do it from a 4-chamber. So TAPSE stands for tricuspid annular plane systolic excursion. I remember I talked about the fiber orientation, those deep longitudinal fibers that are pulling, or that, you know, that tricuspid annulus is then moving from the base to the apex, and it's all because of those deep longitudinal fibers. And it correlates pretty well with MRI, RV ejection fraction, provided you haven't got significant tricuspid regurg. The correlation is definitely less if you've got severe tricuspid regurg. And also it doesn't perform so well in those with precapillary pulmonary hypertension, because they get this rocking longitudinal motion of the RV. You know, the RV becomes more rectangular. You get this pulling across of the fibers. And so you get this overestimation, if you like, of what the RV global systolic function is doing just purely from using TAPSE alone. So we put our cursor down, we use M mode, and we're measuring from the base in diastole to the peak in systole. Try to, you can, if you're going to, we should all use TAPSE, and I think if we're going to do it, we need to do it well. So make sure that your Doppler is aligned as well as possible, aligning with the movement of the annulus from base to apex. And make sure that you are reducing your depth. So ideally the depth should be reduced a bit on this, and we should fill the screen more with the M mode, and make sure that we're doing it well. And we think that we're good at doing this, and it is fairly reproducible based on literature that we have on it. But I think Ben's about to shock us all when he publishes his data on intra-observer, like on how variable we are in critically ill patients, even with what we think we're good at, which is measuring TAPSE. So it's easy to do, but it's also easy to get wrong. And if you're going to do it terribly, just don't do it and just eyeball it. So just take your time a little bit and make sure you've got your angle and everything lined up. And obviously you're looking at that one movement, right? As we've said, you're just looking at the longitudinal motion. We're not looking at that peristaltic sort of bellows effect of the RV. We're not looking at what the infundibulum's doing. All of these really important aspects of RV function, the septum, everything when we're missing. So you just need to bear that in mind when you're just reporting TAPSE. And normal values more than, I use 17 as a cutoff, but 16, 17 doesn't really matter. And, similar for, I guess it seems a bit more fancy, doesn't it, tissue Doppler imaging. So you're looking at myocardial tissue velocities, which are low velocities. You'll notice that this is wrong. It says meters per second. Need to change that, centimeters per second. And again, it's the advantages, disadvantages is similar to TAPSE. You're looking at one regional aspect. It's completely angle dependent. You could be subject to tethering and translational or rotational error, just like you are with TAPSE. It might be that your RV is being pulled rather than actually contracting. So what's this little spike here, guys? Excuse me. What's this little spike here? Anyone? You can see it there as well. And here.
before the S wave.
Yes, yeah.
That isovolumic contraction time.
Very nice, Rishi. And then it's not perfect. I'd probably repeat this, hey, like I've put the measurement here, but you probably want to turn down the gain a little bit to avoid this feathering. And you want to be at the modal velocity. So this is a little bit feathered for me. I would want to repeat that and try and get a cleaner trace. Again, like TAPSE, if you're not getting a good measurement, just don't use it because it's going to be inaccurate. What's this wave here? Anyone?
I can't see the cursor.
Oh, sorry. Let me put my fancy laser back on this one. What's this wave here?
Yes, so this is
It's the E wave,
Very nice. This one.
A wave.
Very nice. And then we have this period, don't we, of isovolumetric relaxation from sort of here to here. No, sorry, from here to here, isovolumetric relaxation. You can't really see it because it's too feathery. Here to here. Okay, let me click off that. So, someone other than Rishi, Rob, do you want to just comment on what you can see here? Let me play that again for you. So 68, she's come to us with ARDS and she's got a history of smoking. This is all you've got.
Yeah, so not great acoustic windows, but I guess the top right-hand side to me looks like, I guess, an off-axis four-chamber, apical four-chamber, focusing on the right ventricle. So it's difficult to comment on its cavity size there because it's off-axis, but I'm getting the sense that it may be dilated and without great endocardial definition, but maybe slightly thickened wall. I'd want to look at it on other views. And then in the subcostal four-chamber, it appears like it could be dilated as well. It's looking like it's similar size to the LV cavity, so that would be sort of getting towards severely dilated in that setting. The eyeballing the longitudinal function, it looks like it's moving a reasonable distance at a good velocity, but I'd want to see what the function of the tricuspid valve and things is as well before I commented too much on that.
What do you think, just eyeballing it though? You've given an eyeball of what you think the TAPSE is and it looks reasonable. What do you think of the overall function though? Do you think it's normal or abnormal?
I think the free wall contraction looks like it's down.
Nice.
Looks like it's impaired.
Yeah.
And with the clinical setting, I'd be concerned about acute pulmonary hypertension from the ARDS, acute core pulmonale.
Very nice, Rob. Yeah, and the history of smoking there as well. Maybe there's some chronicity and there's suggestion, as you were saying, but you'd need better views to look at all of that and contextualize it, look at previous images and all of that stuff. But I just want to draw your attention. You see how the area, so this free wall, I mean, the apex is almost akinetic. It's rocking, isn't it? More than sort of that traction, that inward sort of movement, that bellows effect that you would normally, that squeeze, I guess. That squeeze of the free wall is not happening, but you're getting this movement of the annulus. But you see how the area is not changing of this RV at all. So this is a moderate to severely, this is a significantly impaired, RV systolic function. Sam's going to kill me for using significantly. I would say eyeballing it looks severely impaired. I want to have other metrics to back that up, and I know from this that the TAPSE is going to be normal. And the reason why the TAPSE is normal is that thing that we talked about, that longitudinal rocking motion, which is pulling the annulus, but it's not actually thickening. It's not thickening in that longitudinal contraction. It's being pulled. And so other things that I find really useful clinically is to look at the fractional area change if I can. And that's difficult. You can imagine trying to do the fractional area change on this, exactly where the endocardial border definition is and what's trabeculation and all of this. But the RV free wall strain I think can be helpful, but also looking at your RV or TVTI. And those are the things that I would be doing at the bedside. We can easily do these three things now, with the machines that we have. and you know, definitely not hanging my hat on a TAPSE here. So the TAPSE on this lady was normal, it was 20, but of course we know that looking at this RV is absolutely not normal, and that's the key thing to recognize. And this is what I'm saying about the definitions being messy. I think RV dysfunction, it is just messy. Like, you're going to have patients that have got this discordance because of the pathophysiology of the RV dysfunction. They're going to have this discordance in their parameters, and so sometimes it's just really hard to you know, never hang your hat on one measurement, which, you know, then makes it messy for studies and inclusion criteria. So we did do our best at trying to do the sonographers did trying to do a fractional change on this lady. You know, the end diastolic area for a body surface area was enlarged, so it's dilated. We talked about 12 centimeters per meter squared, didn't we? And then the fractional area change was 25%. So TAPSE normal, but fractional area change down. We see this a lot, particularly in the ARDS, particularly in scenarios where they've got this pre-capillary pulmonary hypertension. You see this discordant pattern a lot. You know, in clinical practice and also reported in the literature. What's a normal fractional area change? Umi?
I'm not sure. Sorry.
No, that's all good. Ahmed, what would be a normal fractional area change?
35, maybe.
Maybe, yeah, nice one, Umi. Yeah, 30, more than 35. So this patient was 25, which is reduced, and there's no scale for mild, moderate, severe, hey, for the RV, which like for TAPSE or for FAC, it's either normal or abnormal. It's quite binary, but we still tend to say it's severely down or it's moderately down. I think hopefully that will all improve. So fractional area change, I like it. If you can do it, if you've got the good enough images, you should do it on all patients because of potentially missing patients by just using those longitudinal parameters which we've talked about. It's pretty good as well at correlating with MRI of ejection fraction. As I say, it accounts for that squeeze, that bellows motion of the RV, and it's got some prognostic data. Of course, all of these parameters are load dependent, right? And it's and this is a drawback of some of them. So the previous one was textbook. This is reality, and this is this biggest drawback, I think, in the ICU. It's a lot of guesswork. Sometimes changing your B color mode, the sonographers gave me that tip, can be actually helpful just to make that endocardial border definition pop a little bit. So going to whatever suits your eye, gold, pink, whatever it is, can sometimes help. I think less routine indices, you know, maybe we are using RV free wall strain a bit more with the better machines, you know, having it just freely available there when we're scanning. And as long as you've got good 2D images, it's quite easy to do. You've got your TEER index or your myocardial performance index. I'm not going to go into a lot of detail with this. You use the same tracing as you would do to measure S prime. And this is why I just mentioned to you about the timings, right? The isovolumetric contraction and isovolumetric relaxation times there. And basically, that you do your total contraction time, which includes your isovolumetric periods over the time ejection time. And the higher this value is, then the worse the RV function is, right? And that makes sense. So the longer your RV is taking, thinking about contracting, but not actually opening that pulmonary valve, because the pressures in your RV have to be higher than your pulmonary artery diastolic pressure, right? To open the pulmonary valve, that's RV afterload. So the longer it's taking to do that and to eject blood, and it's really struggling to get that blood out, then the worse the function is going to be, because that impacts the pressure volume relationship, which I'll show you a picture of. So the key thing to remember is it's the total, you know, the numerator includes your isovolumetric periods, and the longer it takes thinking about contracting, the worse the RV function, hence the higher the MPI, the TEER index, and 0.55 is usually the cutoff with TDI. And then, of course, the gold standard MRI. I mean, this is not feasible in our critically unwell population. I'd love it to be. I heard from one of the intensivist who's currently with us from the Alfred that they have a portable MRI scanner in their ICU. It's not a cardiac MRI scanner, but maybe this will be the future, that we'll have portable cardiac MRIs in the ICU. Wouldn't that be lovely? And 3D and MRIs, obviously, RV ejection fraction, more than 45 and an MRI is sort of gold standard and is beautiful for giving you very accurate volumes and things. And there are other things that you can look at, which we'll not go into because I've running way over time here, you guys, sorry. Strain, again, I will have a whole of the session on this. Normal values is greater than -20. It uses speckle tracking. Now it measures looks at these little kernels. You measure the deformation, so the change in length. So if you start off, you know, you've got your starting length, you minus you've got your new length, you minus that from your starting length over your initial starting length. And as you can see from this graphic here, if you go from this length to 75% of that, then your strain or your deformation is going to be -25. And we can talk about this some more. You should do strain in an RV focus view, which we've talked about, and you get something that looks like this. We have the LV package on our GE machine, so we block out the septum. Maybe we shouldn't do that. You get these lovely strain curves, and this is where your aortic valve closes here. So this is your peak systolic strain, just here, and then it averages that, and that's what the white curve is. And as I said, normal values is more greater than -20. So another pattern, an important thing to recognize is ventricular interdependence, or this septal shift, and this D-shaped septum. So if we're getting flattening in systole, as we know, that's pressure overload, and if we're getting flattening in diastole, that's consistent with volume overload. And that's really related to, you know, these things that we talked about with the as you get more pressure loaded dysfunctional RV with chronic pulmonary hypertension and things like that, or even, you know, maybe, and we see this a lot in acute pulmonary hypertension, don't we, in PE or ARDS, where you've got pressure overload in your pulmonary circulation, your RV is struggling, and then your isovolumetric contraction time is longer. So at the end of systole, the pressure in your RV is greater than your LV transiently, and you get that septal bounce, that paradoxical septal motion. That's what that is. It's that flattening towards the LV at end systole. That's known as paradoxical septal motion. Combine that with your RV to LV ratio of more than 0.6. That's the echo definition of acute cor pulmonale. And then obviously, as you're filling your ventricle, if you are getting you're getting, you know, up that end diastolic volume, you're getting restrained, your RV can't stretch anymore, it's going to start bulging into your LV. You can't go anywhere, it's constrained by that pericardium, so you get flattening in diastole if you've got volume overload. Mostly we see both together, I think, in the ICU, just like this patient. We got it through the whole cardiac cycle. This is, again, as you can see, this is a patient with chronic pulmonary hypertension. Why do I say that? He's got a thickened RV free wall. You can see, because you can almost see the tricuspid valve on fast. There's a pacing wire in there as well. You just get the feel that this is a ventricle that's remodeled and become that rectangular sort of shape. You can see a pericardial effusion and complete ventricular interdependence throughout the whole cardiac cycle. So that's the RV, a whistle stop through size and function and interaction with the left ventricle. Does anyone have any questions about those metrics of systolic function that we look at? I haven't spoken to you about RV diastolic dysfunction. It's too much to fit in, but that's an expanding area as well. All right, let's move on to pulmonary hemodynamics. The RV and the pulmonary circulation are inextricably linked. We often talk about them separately, the same as we talk about the RV and the LV separately. They are absolutely all inextricably linked. We need to start talking about them together and contextualize them together. So we measure pulmonary arteries. So the first thing to do is their pulmonary hypertension, right? So does anyone, the first thing that we'll go to with this is, obviously in your parasternal long axis view, you get a bit of a vibe, I suppose, from whether your RVOT is a bit big, is there a big moderator band, is it thickened? But really, when you come down to your RV inflow view, you get your TR jet in most patients, maybe in 60-70% of patients, you'll get this. You tilt down towards the patient's right hip, you get your TR jet, and that's when you usually get your first TRV max. What TRV max would ring alarm bells for everyone for being elevated, to give you an impression that there could be pulmonary hypertension in meters per second? Do you have a sort of cutoff that you look at as you're going through your scan?
More than 3.
Above 3.
Yeah. about above 3. I mean, yeah, 2.8 is what's in the guidelines, isn't it? So, 2.83. Yeah. So if we have more than 2.8, then we have a possibility. If it's less than 2.8, we think there's probably not pulmonary hypertension. What would be the caveats to this, though? We see this all the time, right? But patients have rip-roaring pulmonary vascular dysfunction, raised PVR. There's two main things.
If there was severe TR or pulmonary
Perfect.
stenosis.
Beautiful. So pulmonary stenosis makes it really difficult, doesn't it? So you need to do your expanded Bernoulli equation, but that's definitely a caveat to using this for estimating pulmonary pressures. But severe TR, you're absolutely on the money. And that's because you get that V cutoff sign, rapid pressure equalization. So it's not going to, it's going to completely underestimate what your pulmonary pressures are. So severe TR and RV dysfunction, hey, so if you've got an RV that can't generate that pressure, you're not going to get that big gradient difference between the chambers as well. Very nice. And then if we increase our index of suspicion when we're getting over 2.8 to 3.4, and then more than 3.4, it's highly likely that there's significant pulmonary hypertension. And these so this patient has clearly severe pulmonary hypertension, and it's likely to be chronic. It's very hard to generate pressures. I'm going to say, above 60 is generally what's talked about. If you've got pressures above 60, you're going to have an element of chronicity. Your RV cannot generate pressures really above 40 acutely without the patient dying. So if you're reaching sort of 60, then you know that you've probably got some chronicity to what's going on. And these values, when we do our Bernoulli equation, so for B squared plus right atrial pressure, which is always notoriously difficult to measure with echo in critically ill patients and inaccurate if they're ventilated, correlates to a pulmonary artery systolic pressure, this 2.8, of about 35, and then a mean pulmonary artery pressure of about 20. So that's the new cutoff. You're probably familiar with that from the 2022 guidelines. Mean pulmonary artery pressure is more than 20 at rest is pulmonary hypertension. So lowered. So it's the first time it's been lowered from 25 to 20. But a lot of the times in the ICU, right, we don't have these TR jets. Depending on the literature that you look at, and we did a study and it wasn't present in about 23% or something. Other people have looked at it and wasn't present in about 40%. So there's going to be a significant proportion where we can't get that TR jet. Or if it's underestimated, for example, if your RV is struggling massively like this, it often doesn't generate those high pressures. That doesn't mean the patient doesn't have pulmonary hypertension, just means that the TR is not good enough to estimate it for you. And so there's other things that we look at. And again, these are taken from the pulmonary hypertension guidelines. And I'm just going to skip through because I want to not have you guys on too late, but if we're seeing ventricular interdependence, if we're seeing massive right heart chambers, if we're seeing a dilated pulmonary artery, big fixed dilated IVC, short pulmonary acceleration times, which I'll talk to you about, and notching, then these are all, and a big right atrium, more than 18 centimeters squared, these are all pieces of that jigsaw puzzle that you put together to think, the TR is not up, but this patient clearly has pulmonary hypertension. And then it's your job to work out with the clinical context and everything, whether it's acute, chronic, acute on chronic, which can sometimes be either really easy, like this middle one's clearly chronic, as sometimes it can be a bit harder. Is this acute on chronic, or is this I keep using my thing and realize you can't see. So this one here would be someone with chronic pulmonary hypertension. That's quite easy to spot, isn't it? But this one, this patient, is this acute or is it acute on chronic? It's a little bit difficult to tell. And so all the things that we've already spoke about to try and ascertain whether what's going on with the patient. Echo is only ever an extension of your clinical exam. So this is what we talked about with systolic pulmonary artery pressures, using your TR jet, adding on your right atrial pressure. Are you all familiar with the cutoffs for right atrial pressures in spontaneously breathing patients? So more than 2.1, less than 50% collapsing, about 15, more than 2.1, more than 50% collapsing, about 8, and then less than 2.1, more than 50% collapsing, about 3, sort of somewhere between that kind of ballpark. And because your mean and systolic and diastolic pressures are all linearly related to the elastic properties of your pulmonary circulation. You can quite accurately tell what the mean pulmonary artery pressure is from your systolic pulmonary artery pressure by timesing by 0.6 and then adding on, depending on what you read, 1.75 to 2 millimeters of mercury. So you can, at the bedside, I just times it by 0.6 and that gives me an estimate of the mean pulmonary artery pressure. Unlike the systemic circulation where they're not linearly related. Of course, with everything, we can get it wrong. And if we've got our gain settings up too much, we're going to be fuzzy. We're going to be using the beard, not the chin. So you wouldn't measure down here like we've done here. You'd put the gain down a bit and you'd measure from here. So chin, not the beard. As you've mentioned, you're going to underestimate it in some scenarios. Your Doppler angle has to be right. So interrogate from lots of different angles. End expiration is the best. If you've got lots of varying ones, maybe that's better to average it. And pulmonary stenosis, of course, it makes it tricky. And if you've got a terrible incomplete trace, then don't use it because you're going to get the wrong information. We can use the pulmonary regurg jet to measure our diastolic and mean pressures as well. So you can use your early PR velocity to measure mean pulmonary artery pressures. So the same, you'd do 4V squared, add your right atrial pressure, would give you an estimate of mean pulmonary artery pressure. And then if you do your end diastolic pressure, again, 4V squared plus right atrial pressure, this will give you your diastolic pulmonary artery pressure. You can see each one of these is different. It's really hard to see exactly where I should put my cursor to measure that. And that's the problem I find with this particular measurement. If it's beautiful, use it. If it's not, just take it with a bit of a grain of salt. But if you're seeing your early peak more than 2.2, again, that's just a little soft marker that you're very likely to have, pulmonary hypertension. If it's more than 2.2 meters per second, again, just that ballpark, the 2.8 and then the 2.2 for your diastolic, for your PR jet, are sort of numbers that I use in everyday practice for that. I find this quite useful in the ICU setting because not all patients have the TR jet, and also because it gives you a lot of information, I think, about the pulmonary hemodynamics. So this is the pulmonary acceleration time. It's the time taken from that onset of ejection, so when your pulmonary valve opens, to reach peak velocity, right? So it's the time taken. I often see people just following this trace down, like just putting a line from there to there and not realizing it's actually the time that you're measuring. That's when you're first starting off using Doppler and stuff. So really important to use the calipers to measure the time. And it's good to zoom in, you definitely don't want more than 3 on your screen, even better if you just have 1. So increase your sweep speed. And then you can measure it quite accurately. It's impacted by heart rate and RV function, so it's not perfect. If you're tachycardic, it's going to make it inaccurate, and you can correct it for heart rate, but then it's more of a fudge factor. So just be mindful that it's not perfect and it's affected by heart rate. You can use this formula maybe, I never use it. Sometimes it's in the reports, but I, again, take it with a pinch of salt for measuring pulmonary artery pressures. It hasn't been validated in critically ill. It's got reasonable validation in outpatient settings. And these are sort of, depends what you read in terms of cutoffs. Normal is more than 130 milliseconds. When you get in towards sort of less than 110, it's reduced. Less than 90, significantly reduced. Reasonable evidence showing that less than 90 milliseconds is associated with PVR of more than 3 Wood units, so significantly elevated PVR if it's less than 90 milliseconds. Big Scandinavian group looked at that, which is quite a nice study. And then if it's less than 60, these are sort of the PE patients, right, with that 60-60 sign. So pulmonary artery systolic pressure is less than 60 because it's acute and they can't generate that pressure. And then accel times less than 60, so 60-60 sign. This is a sign of acute, severely elevated PVR, i.e. you've just blocked all your pulmonary circulation with clot. So that can be useful. But I think that the pattern is particularly useful because, as Sam says, you can't fake this so much. I mean, you can if you get your angle right, but if you've got good images, which you can either get in your subcostal or in your parasternal shorts. I find the subcostal really good for this, so modified subcostal and coming down to open up your pulmonary trunk. and get that beautifully lined with your flow through your RVOT. And if you're seeing this sort of notched pattern, highly suggestive of significantly elevated PVR, you know, way more than sort of 3 Wood units. And this often prompts a change in management for me. So pulmonary vasodilators, thinking, has this patient had a PE? You know, maybe getting a CTPA, again, never using one thing in isolation, putting it together, but it certainly just triggers alarm bells that this patient's got significantly elevated pulmonary vascular resistance. I'd love to talk about this in more detail, but we'll have another session on pulmonary hypertension because it's a lot to cram into one. But essentially, you can have raised pulmonary pressures, right? Because you've got passive transmission from your elevated left-sided filling pressures, or post-capillary pulmonary hypertension. So your LAP coming back, transmitting to your RV. Okay, so post-capillary pulmonary hypertension, or you can have pre-capillary pulmonary hypertension where you've got a problem here, pre-capillary, and that's causing your increased RV afterload. And then you'll have a certain group of patients that have combined pre and post pulmonary hypertension. And obviously patients need a right heart cath to investigate this fully. It's even right heart cath is not perfect for this, but it's the gold standard. But there are some echo features that can give us a clue, increase our suspicion about who might have pre-capillary pulmonary hypertension. And for the sake of time today, guys, I am going to skip through this, but we'll do another session on it, and I'll show some cases that have gone on to have right heart cath or a PA catheter in our unit, and you know, we've confirmed pre-capillary pulmonary hypertension. And as you can see from these publications here and this beautiful paper in JACC, there's a fair amount of literature on this in the non-critically ill, where we can use echo to sort of guide the likelihood of pre versus post. And you might have all heard of this by Greg Scalia's group in Queensland, the EPLAR value, which looks at filling pressures over TRV max. So E to E prime over TRV max gives you a ratio. And if it's high, you're more likely to have pre-capillary pulmonary hypertension. So this is a whole talk in and of itself. I think it's interesting. I think it can help us try to phenotype the pulmonary circulation a bit better, so we can try and understand how the RV is behaving. But we need more work in this area, I think, and it's not easy. Preload is an important aspect of RV function. IVC collapsibility, we've talked about. This goes out the window when they're mechanically ventilated, of course. We can look at distensibility index and all of this. Again, that'll be a talk for another day when we talk about fluid responsiveness. We can look with Doppler, looking at hepatic vein flow, look at the S to D ratio. You know, if that's less than 1, maybe we've got raised right atrial pressures, and there's, again, we can talk about that a little bit more. And we can also look at tricuspid inflow, look at E to E prime on the right side to try to tell us whether right atrial pressures are elevated as well. In the last 10 minutes, I just want to quickly go through pressure volume loops. Everyone gets a bit nervous about it. I just want to go over the key things, and then we can have another session on it. But essentially, I've talked about the RV and the pulmonary circulation. Now, the final part of this for me is putting that together, and that is with coupling of your RV to your pulmonary circulation. And that sounds a bit weird, that sort of coupling phrase, I think, but essentially all it means is that if you've got an RV that's coupled, it's happy because it's chilled out and it's using not much energy to eject blood into the pulmonary circulation. So it's all about RV energetics. And if that's low and efficient, you're coupled to the pulmonary circulation. It's like everything's working beautifully. And I'll show you the normal ratios for that. If it all goes south and you become uncoupled, it means that you're using a lot of energy, a lot of oxygen consumption, etc., wall tension to eject that blood into the pulmonary circulation, and that your RV can become uncoupled from the pulmonary circulation. And then, you know, from that, RV failure ensues. So I think to truly understand RV function, and especially in the intensive care setting, I think we need to understand pressure volume loops, because the interplay between the RV and the pulmonary circulation is so load dependent that considering both of them in isolation, it doesn't allow you to get a full picture of what's happening. So we'll be familiar with this. It is a bit cartoony because it's more like an LV loop, just to demonstrate the key things. So a few key lines are this end diastolic pressure volume relationship, which is our diastolic elastance curve. So elastance is change in pressure for a change in volume. So this, if I could just use my pen, the steeper this curve, if that went up like this, for example, that would be a stiff right ventricle. Okay, so you're getting a really high change in pressure for the same change in volume. Okay, so that's how that one would look. And then this is your end diastolic volume or your preload. You then get your isovolumetric contraction period. Okay, and the length of this actually determines your afterload as well, the afterload line, which I'll show you. Then once this pressure in your RV exceeds pulmonary diastolic pressure, your pulmonary valve opens. All right, and then you have this period of ejection, RV ejection, pulmonary valve closes, empties, okay, and then tricuspid valve opens, RV fills again. The function of your RV is determined by the width of this pressure volume loop, your stroke volume, right? Because the function of the RV is to deliver adequate stroke volume to maintain your circulation without an elevation in central venous filling pressures. That's the function of the RV. When that goes wrong, that's the definition of RV failure, right? So organ dysfunctions related to inadequate stroke volume with elevated filling pressures is RV failure. So you can see that this stroke volume that comes up is really bound by three main areas. And these main areas are this line that connects your unstressed volume to your end systolic point, which is the line, it's called your ventricular elastance, which is your measure of RV contractility. Your end diastolic volume to end systolic volume gradient is your pulmonary arterial elastance or your RV afterload curve. Okay, so if I have a patient with reduced contractility, the slope of this line is going to reduce. Okay, if I give someone dobutamine, the slope of this line is going to increase. So this is increased contractility, this is reduced contractility. And then if someone has a PE, this line is going to increase. Okay, so increased RV afterload. And then if we give pulmonary vasodilators, maybe we'll reduce RV afterload. And again, it's also constrained by, and this is going to change the shape of these curves to give us less of a stroke volume. And again, it's going to be impacted by the stiffness of the RV. Okay, so all of these things will give us a stroke volume. And I'll show you, there's a beautiful paper which you can read more about it. And then essentially the ES, so your ventricular elastance to your arterial elastance, the ratio of those things, your ES to EA, that's your RV-PA coupling ratio. Okay, and normal values is between 1.5 and 2 because your RV is a very efficient ventricle, and so it has lots of reserve essentially. So that ratio is between 1.5 and 2 in health. This is a lovely paper if you want to understand more about coupling and really RV function, which is by Sheldon Magda, called The Tale of Two Elastances. And this just shows what I was trying to show there with the pen. So this is a normal RV. And as I change my end diastolic volume or my preload, i.e. I start giving my patient fluid, push them up this, this preload line, even for the same contractility. So if we just look at this one here. Can you all see the laser? I'm keeping the contractility the same, but I'm increasing preload end diastolic volume. And can you see how the stroke volume is reduced? So from this patient here, whose end diastolic volume is here, sorry. They've got a really big stroke volume, but if I push them up this curve, they're going to be constrained by, the pericardium and the RV, the fact that it can't stretch anymore. So the stroke volume is going to be reduced, okay, if we overstretch the RV. Hence why too much volume to the RV is also not a good thing. If we give them a double whammy and move on to this one where we also reduce the RV contractility, so this would be a patient with sepsis who we've given 3-4 litres of fluid to. We've then shifted them to the right of this curve again. We've already got that reduced stroke volume because we've moved up this end diastolic pressure volume curve. And then we've reduced contractility, so the ES has gone from 1 millimeter of mercury per mil to 0.5 millimeters of mercury per mil. We've brought this down, so therefore our stroke volume is reduced even further. right? So this is how changing preload and contractility reduces that function of our right ventricle. And then this is how changing afterload reduces it as well. So if we keep contractility the same here, but these lines connecting end diastolic volume to end systolic volume is your afterload curve. So as I'm going up here, I'm increasing afterload, and you can see that my stroke volume is reducing with every increase in stroke volume, every increase in afterload. And if I have a double whammy of reduce, and you can see that even if we have that scenario, right, where we've got massively increased RV afterload, patient with PE, ARDS, I've gone from, say, here, where my stroke volume was 90 mils to a stroke volume of 50 mils. I then have a little insult to the RV, so my contractility has gone from 1.3 to 1, so this line is shifted down a little bit. Even if I give them something to improve their contractility, I'm only going to shift them back up to here. So if I increase it by 30%, 1 to 1.3, I'm only going to move them back up here. So even increasing contractility in this setting doesn't massively improve our stroke volume of the RV. And we have to pay a lot of attention, therefore, to RV afterload in these circumstances to try to improve our stroke volume. If we have high afterload and reduced contractility, that's a terrible scenario, as you can see from this picture here. We've got the same afterload curves, but we've dropped our ventricular contractility by half, and we've now got a stroke volume of 10 mils. And this is what we see in our clinical practice. Hey, we see those patients that just have terrible stroke volumes, terrible cardiac index, and this is where they're at in terms of their performance, their pressure volume relationship. I'm going to skip through that and this, and maybe we don't. There's pretty good blueprints for what happens in chronic pulmonary hypertension, and it's very well described. There's beautiful papers talking about all of this, and patients move from this RV sort of injury with pulmonary hypertension to this point of RV PA uncoupling, and this happens when this ES to E ratio to EA ratio falls to below about 0.8. This is when this uncoupling happens, and then after that we see RV failure, and this has been beautifully mapped out with multi-beat invasive pressure volume loops with conductance catheters and cardiac MRI. It's beautifully laid out in the pulmonary hypertension literature. We haven't got that data for the critically ill. It's going to be non-linear, and I suspect it's going to be messy if and when we do start looking at this stuff. But perhaps this is why I'm so interested in RV-PA coupling, because if we can catch patients here, perhaps we can stop them progressing to RV failure. Maybe, I don't know. Are there easier ways that we can do this apart from invasive stuff? It's obviously not very practical to do that. Well, there's pretty well validated metrics, and they're not perfect. There's some controversy as to whether they're even better than TAPSE alone. We know TAPSE probably is a measure more of coupling because of how afterload dependent it is. But there's lots of data showing that this is pretty well correlated with invasive metrics of coupling. And normal values of your TAPSE over your pulmonary artery systolic pressure are around maybe 1.2. In the chronic pulmonary hypertension literature, when this ratio falls to less than 0.3, 0.31, whatever, then that was a sign of uncoupling. So that correlated with that invasive ES to EA of less than 0.8. Okay, so that was what they kind of used as a cutoff for that. We haven't got any correlation of that yet in the critically ill as to when, and patients are all going to, I think, uncouple at different stages. But this ratio has been shown to be prognostically significant in ARDS patients at a value of maybe less than 0.6. And we haven't published this just yet, but we looked at a simplified ratio looking at TAPSE over TR velocity, so not needing to measure right atrial pressure. And as you can see, those with the lower TAPSE to TRV ratio, this red group here, had significantly worse outcomes. So if it was less than 5.9, and this sort of matches what's been found in the pulmonary hypertension literature as well, which is interesting. It needs more work, and could it be an echo sort of marker that we could trend? I was going to show you some cases. Do you want me to quickly show you them without quizzing you, or do you want to talk through them? It's up to you guys. There's a few cases just to show some of the things that we've talked about. If you need to leave, you can leave, and then some of you that want to stay on for an extra 10 minutes to go over these, that's cool. So 56-year-old female who was unwell with the flu, bit breathless, history of COPD. She was an ex-smoker. She had those sort of spidey sense things of, you know, but the RV's bad already because she's got that history. And then she had a metabolic acidosis, her kidneys were going off. She became very agitated and hypoxic. She was intubated and then had escalating vasopressor support. These were her hemodynamics just after intubation. So tachycardic, significant pulse pressure variation, which we talked about, very high CVP, maybe a tall V wave, and hypoxic. Do you want to shout out Hani, Jeff, or Rishi what you can? I don't want to pick on anyone, it's a bit mean of me, but if you want to have a go at describing what you see, any of you.
Sure. Emma, I've got to be a little quiet because my house is sleeping. It's late here at night in Miami.
Oh, hi, Jeff. Hi.
Hey. So quite large RV, probably 4.5, 5 cm in this peristernal with a hyperdynamic LV and some kind of rocking motion, small pericardial effusion. Can see that. Aortic valves opening nicely. The left atrium doesn't look too large here. So looks like just a really thick hyperdynamic LV with a big RV.
Nice, Jeff. These are not perfect, but it's what we have.
Okay, and then clearly pressure overload on the top left with the D'ing out that's pushing back in diastole, at least it looks like. Same for the one below. I can't really make out much more than that. Let me just throw on my phone here. And again, little pericardial effusion appreciated.
Yeah, very nice. It's sometimes it's hard, isn't it, to see whether it's systole or diastole when they're that tachycardic as well.
Yeah.
But certainly lots of ventricular interdependence. Probably, I mean, I know the story, so it's probably in systole as well, but that's me cheating a little bit. Okay, 4 chamber.
Okay, so on this, the apex actually looks like it's more RV. And I don't think it's view. I think it's just the size of the RV, which is at least as large with a thick wall. So I'm guessing at the wall because I'm not seeing a subcostal, but that does look wide. And we got that rocking motion going on. And then the septum is clearly, kind of pushing into the left ventricle from the right ventricle. And it sort of looks like you're seeing a McConnell's up there.
Yeah,
so
it is,
again,
isn't it? Yeah.
for PE, it's there.
Yeah. Very nice. Yeah, absolutely. Can you all see that? That's sort of pulling down at the apex, that hyperdynamic apical movement, an akinetic free wall. So there is McConnell's there. The TAPSE was down, the fractionary change was down, the RV strain was down, but look at all of those curves. I'm not sure I'd be trusting that too much, and the views weren't the best. What do you think of this trace, Jeff?
Sorry, getting stuck on frozen here. So 2 meters per second, clearly under, I won't say underestimated, but the RV is too sick to generate enough pressure. So basically, grossly abnormal. I'd suspect much higher normally, if the RV wasn't so sick.
Yeah. How about this tracing? What is it? And how could you have optimized it a little bit as well? These are the sort of things that they'll ask you in the DDU.
Sure. Don't think I'll be doing that one in Australia, but okay.
Okay. Fair enough.
But so too fuzzy for sure. So need to clean that up a bit. I think that's the main thing, you are going, and that's the acceleration time, which is really fast. It's 0:59, so less than 60.
Yeah, nice stuff. I think things that you could improve, probably not having 4 on the screen, so just increasing the sweep speed. And then also, you know, you can change the low velocity pass, like the pass filter, just to get rid of all this dead space around the baseline here as well. And it can improve your accuracy of where your starting point is for ejection onset. You see how there's this big gap and you don't know exactly where it's coming from. And that's because it's so low and the VTI is clearly terrible. And often you get this drop out there. So just so doing that might be useful. But yeah, so what we can see is like more or less, I mean, it's not a great TR traces, but we got the 60-60 sign that we talked about. And maybe we've got that sort of intermittent notching, or almost sort of that really sort of single spike, which is almost just as bad as notching, if not worse. So yeah, significantly elevated PVR. And you mentioned something already with McConnell's sign, which is giving it away a little bit. But this lady obviously went on to have a CTPA after the echo, which is highly suspected for PE. And she had these big bilateral pulmonary emboli. She was thrombolized, and this is her echo the next day, which is not perfect, but looks a bit happier. The heart rate's certainly better. And it looks all a little bit better. Do you notice this structure here?
Coronary sinus.
Yeah, it's massive, isn't it? It's huge. You can see it a bit on the initial one as well, because she's so fast and there's lots of other things going on. You can easily miss it. So what things might you think about this dilated coronary sinus, Rishi, just as a side point? What could be causing that?
Raised
ASD.
right atrial pressures.
Yeah, from what reason?
Just filling back pressures and increased right ventricular pressure overload or
Yeah.
severe.
Yeah. So sometimes you see it in severe chronic pulmonary hypertension patients, don't you? But there's also one other thing that you might think about doing and checking for as well, if you see a dilated coronary sinus. A persistent left SVC, yeah, with a bubble study. And you can see that the ventricular interdependence already the next day is starting to look a bit better. This is a patient with a 72-year-old man that had COVID ARDS, who had a significant deterioration in his hemodynamics and respiratory requirements. He was intubated and ventilated. Rishi, might you want to comment on what you can see here?
Yeah, again, the patient is quite tachycardic at 145. RP is the RV outflow tract looks grossly enlarged, with no effusions at this point. Again, grossly dilated coronary sinus, or maybe dilated coronary sinus, not grossly. It's the descending aorta.
That's descending aorta. Yeah, nice. Yeah. This isn't actually this patient, but it looked similar to that. But
yeah. So again, in the subcostal, parasternal short axis view, there's a D-shaped septum with evidence of pressure and volume overload. And again, with a RV, which is at least equal to or more than the size of the left ventricle. In the apical foot chamber view, showing again a RV is more than the size of the left ventricle with a large right atrium as well. The TAPSE, there is a bit of longitudinal movement, but that is more than the lateral inward movement and the apical movement. But even the TAPSE seems to be reduced. The excursion seems to be visually reduced, but needs to be confirmed.
yeah, nice.
But again, the wobbly rocking movement of the heart, again, also such pointing towards severe RV pressure and volume overload, either
Very
related
nice.
to the ARDS related.
Very nice. Yeah. So the TAPSE was just a little bit down/normal, and the S prime was normal, lower end of normal. So in ARDS, obviously this patient had the features of acute cor pulmonale from his ARDS. He did have a CTPA and it was negative for PE. And I think he had a little bit of chronic lung disease and a bit of mild pulmonary hypertension in the background. But we see acute cor pulmonale in ARDS around 20-25% of the time. These are the risk factors from the famous sort of DeSapp paper: driving pressures more than 18, PF less than 150, CO2 more than 48, and if they've got pneumonia. And if they've got 4 of these things, then they've got a really high risk of developing acute cor pulmonale. And this is what I was talking about at the beginning, about we're never going to have this perfect metric, right, for RV dysfunction. It's about putting it all together, which is kind of what you just did there, Rishi, and also Jeff in the first one as well. You know, the longitudinal, it looks dilated, the longitudinal function looks maybe all right, but the fractionary change, that radial function, looks terrible. There's features of acute cor pulmonale, more than 0.6, paradoxical septal motion, and then it's, you know, putting this together. So in Stephen did this last year. It was a sub-study from the Echo COVID study, which probably some of you have read, and they looked at these you know, the phenotyping of RV injury, and they defined acute cor pulmonale, as we talked about, RV failure as RV dysfunction. So TAPSE less than 17 plus a CVP of more than 8 is what they, you know, they're using their cutoff, or a dilated IVC. That's how they defined RV failure in the study. And then acute cor pulmonale, you know, plus these things, so plus RV dysfunction plus RV failure, and looked at the incidence, and you can see, you know, the incidence of ACP, of RV failure over time in the ICU, and how prevalent that was. And I guess the interesting thing was RV dysfunction in and of itself wasn't associated with increased risk of mortality, but RV failure just about reached significance, but wasn't really. But what was consistent with the previous study by DeSapp and stuff was acute cor pulmonale, obviously in the setting of ARDS, this is with COVID, was significantly associated with increased risk of mortality. So I think this is what we're going to be moving to, these sort of patterns of RV dysfunction, rather than hanging our hat on one single value. I just want to show you an example of chronic pulmonary hypertension. This is a patient who was fairly young, who came to us with cellulitis and septic shock, quite sick, and you can see that he's got, you know, this rectangular remodeled RV. It's apex forming, it's massive. The RV free wall looks thickened, even though we've not got it in the subcosta. You can see here lots of trabeculation. You can see a prominent moderator band. There probably is a trivial pericardial effusion. The coronary sinus is a bit dilated. You've got that ventricular interdependence happening in systole and diastole. And his metrics were all down, so fractionary change of 16, S prime of 6 centimeters per second, TAPSE of 13. He had a big right atrium. So all of these features, as we talked about in the beginning, you know, suggestive of pulmonary hypertension. Pulmonary pressures of more than 60, again, keeping with chronicity. His RV free wall was thick, and then, you know, other parameters that we can look at for pulmonary hypertension. So putting all of these pieces of the jigsaw puzzle together, you can say this patient likely has an element of chronic pulmonary hypertension, has been decompensated by sepsis. I need to know his usual physician, want to look at his previous echoes and sort of put all that together. And often these patients, this is a lovely paper as well, it's called The Tale of Two Hearts, and it talks about different RV phenotypes based on pressure volume loops. And this patient fits this completely. So he has chronic pulmonary hypertension. Because he's sick, he's sort of shifted up here. He's had a bit of fluid resuscitation. He's dropped his stroke volume. His coupling index has gone down. And we actually just gave him a furosemide infusion and a low dose dobutamine, and he got better. This is a lovely paper talking through all of that. That's it. That's it up there. Ryan Tedford's in it. It's a really nice paper. I think combining that with the Sheldon Magda paper, I'd recommend those two for extra reading. And remember, it's not always pressure overload. This is a patient we had not that long ago with an RV infarct, was hypotensive after having a stent. This structure here is a PA catheter. Remember, McConnell's sign is not just in PE. You can get it with RV MIs as well, which is what we saw in this lady. Concordance between this time, right? So it's not a precapillary pressure overload problem. And this time we can see that there's concordance with the S prime being down and the fractionary change being down. So all of the parameters were sort of concordant this time, which is sometimes what you see as well. cardiac index was down, low SVO2, ejection fraction down, high CVP, all the hallmarks of cardiogenic shock from isolated RV failure, which is not that common really. You know, it's not that common to see RV infarcts so much anymore, I don't think, isolated. And again, showing how these patients behave differently to chronic pulmonary hypertension patients. You know, it's there after their contractility line that's fallen, and often these patients need that little bit of filling for that pressure gradient, right, from the RV to across the pulmonary circulation to deal with that elevated sort of wedge. They don't need heaps of fluid like was previously thought about, but they need a reasonable filling pressure to get you know, to get blood flowing from one side to the other, and obviously support and then mechanical support if needed. This lady actually got better with a little bit of fluid and inotropy and time, and she didn't end up needing mechanical support in the end, but we thought she might have needed that. And the trend of VTI, this is what I do on every day-to-day practice, because this is what I find most useful, as I talked about, that subcostal view. Sick man with pneumonia, bit of lung disease in the background, RVOT, VTI, 7.6, right? Terrible. So normal's about 16. Started some milrinone. This is him 24 hours later. And this is what we need to be looking at. This is what we need to be looking at. It's the trends, right? A lot of the studies are just looking at snapshots. And so we get slightly better view this time, already eyeballing it, it looks a bit better. It's now gone up to 13. So he's got this, you know, recruitability, I suppose. Maybe it's with time and his pneumonia getting a bit better, but I think the milrinone did help. And then the next day it was even better. It was like 16 or 17 or something, and he was off all supports and sort of got better. So that soft hands approach, one thing at a time, detecting it early, having a high index of suspicion for it. And I love the trending the VTI. I just think it's really practical, you know, whether you do it on the left side or the right, but I often find it really quite easy on the right to do. And then there's times, of course, where we need more than a transthoracic echo. Obese patient, you can't see a thing. He's got all the, you know, nitric on, ARDS, pretty bad. It actually was more atelectatic than ARDS. I think he's got some levosimendan running in the background there. Kidneys going off. This is what the X-ray looked like. You know, highly suspicious for some RV involvement here, and couldn't see very much with the transthoracic. Get the suggestion that the RV is a bit big. I just want to point out this septum movement here. People miss this a lot, I find. I just want you to keep your eye on that. That's classic paradoxical septal motion. You're just seeing that dip just at the end, very transient at end systole. It can be missed if you don't train your eye to it. So the filling features for acute cor pulmonale, but difficult to tell. So we did a transthoracic echo, and this is beautiful, hey? So ratio more than 0.6, and you see this beautiful paradoxical septal motion there happening, and also really high right atrial pressures with bowing of the septum towards the left. The last thing this patient needs is volume. We need to pay attention to his ventilation, his gas exchange, all of the good things for the RV, which I know I'm teaching. I'm preaching to the choir and teaching Granny how to suck eggs, telling you all this. I just want to point out as well, though, that this free wall of the RV, the lateral wall of the RV, compared to the RV outflow tract, the RV outflow tract is better, isn't it? It's a bit more preserved than what's happening here, just that regional thing we talked about at the beginning as well. I did a quick video on a really quick assessment of the RV with TOE that you can watch on our website. I think it's quite useful as a live recording, just going over some basic principles of what you would look at. And this chap had, you know, all the hallmarks of RV dysfunction, both clinically, hemodynamically, and on echo. And he actually just got better with, again, simple strategies. This is a lovely paper, and I think it's definitely a talk for another time, how we manage these things. I've talked about how we might diagnose them and monitor them. Obviously it all comes down to this, because there's no point doing all these things if you don't know what to do with the information. This is where the rubber meets the road. This is where we can potentially help our patients. Obviously diagnosing it is key first, but this isn't quite a nice paper. It's not really specific to the ICU population, but there are some you know, Antoine Viard-Brown's an author on it and things like that. So it is still quite nice. It's actually really, really nice. And I'd recommend again this to look at with those other 2 articles that I've recommended, just to sort of give a bit more completeness to this talk. And I'm terrible for going over, and I'm not going to go over any of that conclusion. And I'm sorry to keep you half an hour later, but I hope you learnt 1 or 2 things. And yeah, appreciate you joining. And I look forward to seeing you in person, Rishi.
Thank you so much, Emma. Same
Okay,
here.
see you. Bye. Bye.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.